Hello, Prof. Canata, how are you? Good afternoon, I think is there at the moment. I'm Faisal Alam. I'm the vascular surgeon here at the Royal Hospital and president of the Vascular Society in Oman. How are you?
We are doing
Hello.
fine, sir. We are waiting.
So it's glad to meet you. My name is Lowell Kabnick. I am the chancellor of the Vein and Lymphatic University globally. Previously, the head of venous intervention at NYU, and now I am teaching around the world. And I'm presently here with Professor Victor Canata in Paraguay. And what I'd like to do.
Hi, Professor Kabnick. We are really honored to be live with you, actually, you see. And thank you very much for accepting the invitation and to actually take us through your great experience in this field, actually. And it will be, I'm sure it will be a great session with both of you, Prof. Kabnick and Prof. Canata.
Thank you very much for the honor of allowing me to do this. This is what I want to do for the rest of my remaining career, is to give back. I've spent 40 years in terms of vascular surgery, and actually gave up arterial surgery in 1999 because we didn't know enough about venous disease. We still don't know enough about venous disease. I think we know more about arterial issues than we do about venous. So I don't know if you can see me, but I'm going, can you see this?
Yes, I can see, yes.
This is a entry needle that I'm going to use today. It's a 21 gauge needle. And through the 21 gauge needle, I'm going
Dr. Lowell. Dr. Lowell, sorry, I was muted for a while. I'm Ayman. How are you?
Oh,
We would like to really thank you, Lowell, and Dr. Victor. Just to introduce, sorry, I was really muted, now just unmuted. So we are really happy having you with us in Oman Vascular Society, which is a leading vascular society here in Oman. We would like to welcome you, Dr. Lowell Kabnick, the previous president of American Venous Forum and the leadership of Vein Lymph University and vice president of International Union of Phlebology. You don't need any introduction. You are well known in teaching. You're, as I said in the webinar, phlebology giant. In addition, we really welcome Professor Victor Canata, which is the initiative of this webinar. Whenever we asked him for teaching things, he's always saying yes. He's a Vein Lymph University president and past vice president for International Union of Phlebology. We really thank you. And this is an honor being with us actually today. In addition to Dr. Khafir from Argentina, thank you all for your presence here. I would like to introduce our dearest Dr. Faisal Alam. He's the president of Oman Vascular Society. Dr. Faisal, the speech is yours, dear.
Oh, thank you, Ayman. I've already spoken with both Prof. Kabnick and Professor Canata, and we are, as you said, we are really honored to have them both on our live webinar here for the first Oman Vascular Society webinar in this year, 2025. And as Prof. Kabnick was saying, we were not knowing much, we don't know much about the veins, and his experience today will, of course, shed a lot of light in our understanding for the venous disease and the especially with these techniques he has been pioneering all these years. And we already have lots of members who are in the session, and hopefully, I mean, today this session will be really enlightening to all of us in the coming 2 hours. So without any much delay, I would like Prof. Kabnick and Prof. Canata probably to start. Thank you very much.
Well, thank you very much for that kind introduction. And Dr. Canata just stepped away. But I would make sure that we're all available for any of the questions that anybody has in the audience, because that's how we learn and that's how you learn. So I'm going to start very simply with the type of procedure that we're going to do and some of the instruments that we use to do laser. So we're going to be utilizing laser. There are other thermal devices that you could use, and that could be radio frequency. And right now there is HIFU, high intensity frequency ultrasound, which is thermal. Some of these are minimally invasive and some are non-invasive. Laser is minimally invasive, but if you remember where we came from stripping. And that was, as you know, could be very traumatic to the patient. When I started doing stripping, we kept the patient in the hospital for a week at bed rest. It was typically done under general anesthesia. By the time I got to training, past training, we were now down to sending the patient home the day after. And then I saw this idea of using a minimally invasive thermal ablation. And at that time, it happened to be in radio frequency. And I said, this is something that's going to revolutionize the treatment of venous disease. And then subsequently after that, radio frequency laser came in. And at that time, laser was infinitely quicker than radio frequency. I must add right now that radio frequency and laser are equivalent in terms of clinical equipoise. So they do the same thing and they have really the same results. But today I'm going to show laser. So how we start is we start with a entry needle, and the entry needle is a 21 gauge entry needle. Now there are other entry needles, and in Europe, a lot of people use an 18 gauge needle, but in the United States, we use a 21 gauge needle. And through that 21 gauge needle, I'm going to insert an 018 wire into the vein so that I have now access. I'm then going to remove the needle. And through that needle, through the wire, I'm going to use a 6 French introducer. And the reason for the size is that it's got to be able to accommodate our laser fiber, which I'll show you. So I'm going to, as if I had the wire in, this is what it looks like inside the vein. And then I'm going to remove the wire and dilator introducer. So this is still in the vein. And then I'm going to take the laser fiber and insert it. Now you'll see that there are markings on this, and they're important to know about pullbacks. So when we get to this mark is when I'm going to remove the sheath from the skin, and I'll go over that when we're doing the procedure. These are centimeter marks. And the reason for the centimeter marks is that we want to make sure that we know that we're delivering enough energy to the vein wall. So essentially, this is what we call a never touch, or that it is different than a bare tip fiber. And this is a bare tip fiber. And you can see the difference between the two of them. One's covered and one's not. And there are advantages of both. But today we're going to use, for the great saphenous vein, a covered fiber, which then diffuses the energy to the side walls. Now there's also another fiber called a radial fiber. And what this does is it actually sends the energy circular to the vein wall. So it's not forward, it's side wall. They both have their advantages and disadvantages. But today, because of our setup, we're going to use the never touch. And this will go in through our introducer sheath, and then we will essentially feed this all the way up to the saphenofemoral junction. Once we're at the saphenofemoral junction, we're going to pull it back to 2 centimeters to 2.5 centimeters because the energy tends to splay out. There are other different sheaths depending upon what you want to use. This is a longer sheath, and we will show you pretty soon what the radial fiber is. This is a sheath that's a long sheath that goes over a 035 wire. And sometimes you have saphenous vein, whether it be the great saphenous, small saphenous, anterior saphenous, that are not straight. And sometimes you need the help of a wire. This is a longer sheath and it's hydrophilic and braided, so it's pretty strong. A lot of people in the US, when they use Never Touch, utilize this type of fiber. And now I'm going to show you the radial fiber, which sends the energy directly to the sidewall. And you can see the aiming beam thus forward. So that's what we're going to do today. Is there any questions?
Yes, Prof, you said when you introduced initially, you started, of course, using laser and this under local. So how many of these cases you do them under local, and do you actually do under GA as well sometimes?
Okay, that's a really good question. Why are you laughing, Victor?
We do in 2 days here more than 10. You are doing more than 30 years. It's like a 10, I don't know.
So anyway,
Numbers.
it's a really good question. And so originally when I started in 1999, because we weren't exactly sure what we were doing, we started under general anesthesia. And then within about 6 months, the idea of using tumescent anesthesia, which is dilute local anesthesia, came into fruition, and we started using dilute local. So we moved from the office from the OR in our hospital directly to our office. And it really was amazing because patients really did well. They wanted to come to the office rather than going to the hospital because, as you know, as you go to the hospital, there are several hurdles that you have to clear. So the majority, I would say 99% of the cases are done in our office.
Okay. So the cases which then you decide to do under GA is because the patient tolerance or the pain threshold and all these things, or is it?
So the patients that we do in the hospital, which are few and far between, are those that we feel will not be able to tolerate the local. I mean, even if we give them a little bit of oral sedation, which is what we do in the United States occasionally, then most of them really, when I was at NYU for 11 years, I think I took one patient out of, hundreds, maybe 1,000.
Let's see if there is any other, Dr. Ayman, if you have any other questions in the chat box there.
That's great. What we do.
Yeah, I'm following the chat box. If anyone has questions, please tell.
Yeah, I have another addition. What we do under local anesthesia is we usually talk to the patient. And so we kind of use verbal anesthesia plus local anesthesia, which makes it work that much easier. And if I'm not talking, it's up to the medical assistant or the nurse that's in the room. And we only utilize one assistant in the room in the United States. And they're not usually nurses or medical assistants.
Right. Prof, what about if you have multiple stab avulsions to do as well on top of the ablation of the long saphenous vein? Do you still go ahead with the local, like you continue with local?
So the answer to that is I'm a one and done person, which means I will do the truncal venous insufficiency ablation. At the same time, I will do phlebectomy under local. Now, if the patient has a large amount of them, I will separate that only kind of going toward those varicose veins that are coming off the saphenous, that are truncal in origin, and that are 6 millimeters long. As you know, in some of the studies, even using thermal ablation, that at least 30% of those veins, varicose veins, will disappear. And it's usually on the zone of influence. For example, on the great saphenous vein, it's the medial thigh, medial calf. Now, if you have posterior ones or lateral thigh and lateral calf, that's a different story. then you have to find the origin of that. So typically, yes, we do, but if there are a lot, we stage. Now, when we do non-thermal, it's to me silly to do phlebectomy under local at that time. So a lot of us will stage that. We'll do the ablation, non-thermal, and then come back at a separate sitting.
Thanks, Prof.
Lowell, what's your protocol for short saphenous? Do you still use thermal or do you add some tips and tricks in that?
So we still use thermal ablation for small, or as we call it, as a small, short saphenous vein. And, you know, it's funny, we call it the small saphenous vein because we understood that if we called it the short saphenous vein in the United States, that our insurance companies would pay us a short amount of money. No, I'm just teasing there. But we do call it the small as well as the great saphenous. So, but anyway, the answer to you is yes. The trick of both of these procedures is to avoid nerve damage and obviously any destruction or injury to the deep veins. So in the great saphenous vein, we know that the issue with that is the saphenous nerve. And we know that there are touch points roughly around 10 centimeters below the tibial plateau and then down to the ankle. So as you know, when some people still do stripping, but we found that when we did from groin to ankle, that we had more injury to the saphenous nerve. So we stopped doing that and we went to just below the knee. And that's what we learned from thermal as well, is that we don't want to go down. And now people, because we have non-thermal, will go from the knee up with thermal and then below that non-thermal. Same thing with the small or short saphenous vein. We do it by the confluence of the gastrocs and go up toward the popliteal if the small saphenous vein enters there, or if it does not, which it happens in 30% of the time, then we'll treat accordingly. But when we go to the small saphenous, we go as far as the same idea at 2 to 3 centimeters below the junction, but you can't necessarily see that all the time. So we use the angle of descent. So as the electrode or fiber start to descend into the popliteal is where we stop or where we start our ablation. And then we go to the confluence of the gastrocs. If that does not solve the issue, then we'll touch that up with non-thermal, and usually that'll be type of sclerotherapy.
Wonderful, wonderful, Kabnick. The terminology of flipbo suite. What do you think about it? Having a flipbo suite with ultrasound, small anesthesia machine, clacks for these spiders. Do you agree with that, or is it the trend now in the States?
So you raised several questions within one, and that depends on what your beliefs are. So in our procedure room, it's just like a procedure room. There's a table there, there's a roll-in ultrasound machine, and that's about it. We don't have a small anesthesia machine or any of that because remember, we're in our office. Although there are some outpatient facilities that you can go to do this, but the majority of us don't. And there's rationale to it. One is that you don't need to. Two, we also get a facility fee as well as a professional fee. So that obviates any of the difficulties. But you did mention things like clacks. Now, clacks is a different story for sclerotherapy and as well as laser together. And so if you are going to do clacks, then you will have a laser in your room as well. So there's equipment in your room, but the only thing that I don't see, in at least in the United States, is an anesthesia machine. I really think that once you're comfortable with this, you'll see that you don't really need to have conscious sedation, or as we call it, unconscious sedation.
Rob, let me answer that question too. If you saw this room is well fitted in the way that we saw regarding about the Flevo suite. You got a laser, then you will see at the side also that they have like a machine of sonogram machine. There are another laser over there, and this is a small equipment just to check vital signs of the patient, meaning that you have almost all your requirements, no anesthesia machine at Lowell set, having everything in one place. We have over here in my office, we have three different places. This is the smaller one, and this is the final idea to have everything, trying to do everything in the office. Lower.
So at NYU, we had a surgical table that went up and down and gave us Trendelenburg and reverse Trendelenburg. We had a monitor on the patient, and then we had our RF and laser machine and ultrasound machine, and that was it. So it's dealer's choice, but obviously between both of us, we don't have anesthesia capability here for that. But again, if you rely on anesthesia, you're going to do it all the time. Now, I have a colleague or two in the United States that have an anesthesiologist come to their office to do anesthesia. But for us, our patients really don't go to like stage 1 or stage 2 of recovery. We give them our discharge instructions, and then they go home, because the quicker they start to ambulate, the better it is for them. So that's what we do.
Wonderful, Captain. Another question, compression. Do you use compression post-laser?
So the answer is yes, I do. And the short answer, the long answer is I'm not sure it works. I don't think that there are any really good studies to show that there are decreased, I'm sorry, about efficacy. So I've been known to say, the patient, we used to wear it a week. Some people do 2 weeks, which I think is a little bit long. It really depends if you're going to do phlebectomy with it. If I'm not doing phlebectomy, it's overnight and they're free to go. We used to wait until patient recovered a week before they really were allowed to do vigorous exercises and that. And I learned through my professional athletes that they don't have that time to do that. They need to get back into training right away. Yes, I do decrease some of their training, but they're full boat as far as I would be concerned in my activity level. So the skinny answer is, depending upon what you're doing, at most maybe a week. And for me, the answer is to the patient. Are you feeling better with the compression or not? If you're feeling better with the compression, wear it. If you're not, don't wear it. I personally wear compression all the time, and I'm here in Paraguay at 90 degrees, and I'm wearing below knee compression because that's what I do. Because it makes me feel better. Is it helping me? I don't know. It may, it may relieve some of my edema, but that's the long answer.
Okay, we are moving forward.
Okay.
We will just go to the room, or we'll start. Dr. Kabnick will change, Dr. Canata will change too. Then we will start moving forward regarding about showing you the case and the procedure. Okay?
All right.
Okay, Victor. Meanwhile, Dr. Victor and Kabnick are preparing for the case. If anybody have a question, please put it in the chat box. We have Dr. Ahmed Al-Roufi. Thank you for your questions. If Dr. Victor and Lowell can have time, the question is, what's your VTE prophylaxis protocol? I think they are preparing.
I'm here. Yes.
Hi. The answer to prophylaxis really depends on how serious the patient is, in terms of risk factors. If you can use a multiple of scores that are out there, for example, a Caprini score, but none of them have really been vetted. So the answer is, if the patient has previously had a DVT, I'm going to prophylax them. If the patient's family has had a DVT, then I'm going to consider it because of hereditary reasons. If the patient has had a endothermal heat-induced thrombosis in the past, I will also consider prophylaxis. Now, the question really is, how long do you prophylax? And nobody knows that answer at this point. Some people 24 hours, some people 7 days. Anyway, there's a new study going on in the United Kingdom, and they're going to look at patients that are post-thermal, and they're going to prophylax those patients ahead of time, either be 1 day, 7 days or more, or no days. So they're going to be looking at that. And I think that's going to be interesting for us to understand.
So this means you can treat patients with previous DVT, which some people avoid.
So the answer to that question is, as long as the profund is open, if you've had a femoral DVT, that's fine. If you have a iliofemoral DVT, you're going to want to make sure that you're going to do something about that first. But what we were concerned about originally was the idea of having a femoral DVT, and that you shouldn't do it because the saphenous thing is now anything false to our state in terms of the size of the saphenous vein. They could also look at the flow, but it's not a deterrent anymore.
Very good.
While taking the consent, Prof, do you mention about recurrence, and what's the percentage you mentioned to them?
Recurrent, I'm sorry.
Recurrence of the recurrence rate. Do you still mention?
After ablation?
Yes.
Is that what you're asking?
Yes.
So
yes.
the recurrence rate after ablation depends upon whether you're using what thermal, but it's in small percentages. So 95% success rate at 5 years, probably 90. Now, if you're doing non-thermal, that has a little higher failure rate. And so, but they're all really pretty good in essence. Now, if you look at stripping, which really has another problem called neovascularization, which has a significant amount of recurrent varicose veins, because if you wait long enough, there's neovascularization in most of those patients, which to me, when you ligate all of the junctional tributaries, which is standard procedure, where do the capillary venules, reticular veins, some of the regular veins drain? So we call it frustrated venous drainage, and those small veins start to dilate, and then they also then reflux, and they can cause other issues. So the idea of recurrence rate with stripping and the idea of recurrence rate with thermal ablation or non-thermal ablation are different etiologies, but the same amount occur whether you're doing stripping or thermal ablation.
Great. Thank you.
We really thank the patient for being giving the okay to see this procedure, and also to the staff helping you, Kabnick. So thank you, all of you.
So I'm going to start. I'm going to line up things, and we'll go to the table here. Before I do that, excuse me. Before I do that, I want to present this patient. She's a 48-year-old female who has no past medical history, as well as no past medical history. And she presents with pasty, which is heaviness, achiness, swelling, throbbing, and itching. And she has had no procedures in the past. And interestingly enough, she does wear compression because at her job, which if you come to Paraguay, you might meet her, but she's part of the security at the airport in terms of scanning. So you want to make sure you're friends with her, but most of us don't have anything to declare anyway. So that's she in regard. So I'm going to do the right leg for the audience. She also has some phlebectomies to do, or varicose veins that we're going to do. We could do either phlebectomy or sclerotherapy on those areas. And then off camera, I'm going to do the left leg as well. So anyway, we're going to get ready and we'll join you in a moment.
Well, can you tell us where is the setup settings for your preparation?
You've changed my setup.
Oh,
Yes,
everyone, do you want or which?
just those 4 French. I'm looking for 6 French.
Okay, I'm gonna get all 6 French.
What's it?
Each person. Like that one? Nope.
Bonito.
You want short 6 French?
You're gonna be short 6 French?
Yeah.
I'll take the short.
Okay. You don't use them.
No. So let's see, we have the needle here, local first, needle. I'm waiting for the 018 wire and the introducer.
So everybody, if you want to see the screen of the surgery, you can click on the speaker view. It will show a big window that's showing the case. Also, everybody, if you'd like to post your questions while the case is there, and Dr. Lowell and Victor will answer either during the case or after. So feel free.
So while we're waiting to set up, I'm here to, oh, here it comes. What do you take this one? Let's take this. And then rename this one. Save. And then this too. All right, let's see what we have. So typically I stand when I do this procedure, and because in Paraguay, we have a flat table that doesn't raise with my height. So I'm trying to sit down and make myself comfortable. I will now ultrasound just to see what we're looking at. So I'm going to bend her leg out. I need the ultrasound. And I need some gel. And typically I do this in a, not a break room like it is now. And we're going to look at the vein, saphenous, and we can see it here. And that is in the area, you can see it's in its own compartment. We're going to trace it all the way up to the junction.
Can I request the cameraman to go around and show us the screen also, please? You can.
I want to show the ultrasound.
Acerca a tu cámara, hacerle foco a tu cámara, Victoria. Acá no hay.
So maybe if the cameraman with the Lowell can show the ultrasound,
Can you see it now?
because we can see only the speaker's view.
Okay.
Big.
You have to change.
Big one.
You have to change that to in your screen. Change to multiple, not in the speaker view. Go.
Yeah, multi-speaker's view.
Yeah, use multi-speaker view and you will see both screens. You got it?
Yes,
Yes.
we got it, yeah.
What I'm saying now is the terminal valve as well as the subterminal valve, and neither one of them are working, and that's the junction here with the femoral.
Any?
So now I'm going to go back and I'm going to look. Thank you. And I got to figure out where I'm going to go. And so typically I try to go to a point where we're refluxing, and we're refluxing just to below the knee. But I'm just going to take a look at it as we go. Freeze buttons list. So as you do these things in different locations, you have different equipment, which is also very interesting, which makes it a challenge for the operator. Oh, here it is. You gotta bend your leg, that's great.
Nice.
And I'm gonna do a little local. There are some people that don't do this. Of course, she's nervous now, and this vein usually was about 6 or 7 millimeters, and as you can see now, it's not that. The longer we wait, the smaller it's going to get. And so now I'm trying to approach this long axis. And I'm looking for my needle. And there's my needle, you can see it. And you can see
Yes,
that I'm
clearly.
on the vein wall. And sometimes what happens when you do that, you don't get into the vein wall, into the vein. And I'm going to try and lift it up a little bit and push a little bit harder and see if I'm getting any blood flow. And I'm not getting any blood flow back. So I'm going to, the litmus test is really to see if you can see blood flow back. And so I'm going to try and see if we can get in with my 018 wire. But if it doesn't go in easily, I'm not going to do it. But it did. So
Yes.
here's a trick.
Wonderful.
The trick is sometimes you will not get blood flow back because sometimes that needle, the end of the needle will get clogged with adipose tissue or something. But here you go, and you can actually see it as it goes all the way up. I will show you in short axis that you can actually see it. I'm not sure how your transmission is.
Looking for in front of you, Lowell.
What?
Over there.
What you could do then to help us out is to dial that intensity back so that they can see it. The switch here needs to be turned from an ultrasound.
Dale más, Julián.
Yeah, counterclockwise.
That's good.
That's good. Thank you. All right, so here we are. And I am now, lights on, please.
Yeah.
I'm going to use a little bit of a knife. Lights on, please. And I'm going to use a knife just to make a little puncture here. Typically, you don't need to, but I think it heals better. And so it's just a little bit of one here. And then I'm going to use a short introducer. And it's luxury that I have Javier helping me by giving me instruments. And that's nice. But typically we don't have that luxury.
So was the skin prepped already from before? And what did you
Yes.
use for skin prep?
I will pass that.
We use peroxide plus seal. We don't use betadine over here anymore because the reason of that is usually at the end I do phlebectomies and I miss so many small veins if I use betadine, you know, and the betadine stain the skin too much and give it to you a hard time trying to find out where are the small veins, meaning that we use just peroxide and plus a little bit of chloruro de benzalconio is like some kind of disinfecting agent that you use to make sure that the skin is already prepped.
Victor?
Yeah.
The
And then I can
So-
see that you don't use drapes anymore.
No, we don't need you. We use drapes at the side, below, and everything. Everything is clean.
This
We
is-
don't big trouble.
You need to have a better one than this because it's blunt. It's
Okay.
Going through the tissue.
You want to get another one?
Yes, please.
Okay.
See.
Let me get them. 4 French introducer and
If you bring me the fiber, I can tell you whether it'll fit. So right now I'm just dilating the track because the introducer that I have had a little bit of a blunt tip, so it didn't go through the skin. So another trick that I'm showing you is to be able to dilate the track. And if I had a larger, no, where's the other dilator? Yeah, I'm gonna see if that'll go in. If you notice the difference here is that this comes to a tapered tip and this one is not as tapered. So that's where it's hanging up in the tissue.
Sorry if the one moderating the host and the waiting room, some doctors are asking if you can let them in.
Okay.
Thank you, Victor.
I thought you meant the waiting room here. I was going, wait a minute. So I'm waiting for the proper equipment.
Doctor,
If there are any questions, I will be happy to answer them right now.
So preparing tumescent, what's your protocol, Captain?
So the tumescent anesthesia really depends on where you are. We use a standard tumescent anesthesia, which goes 500 cc's, 50 cc's of 1% with epinephrine. And then we also make it basic by adding sodium bicarb to neutralize it. Now it's the epinephrine that causes the real burning of it because the pH for that is low. It's about 2. So that's why we buffer it.
Yeah.
We see. Don't go anywhere. No, no, no. It's the same. The tip doesn't go all the way down. That's the problem. Let me see if I can dilate it.
You want to have another line, I can give it to you. Maybe all the data are given.
If you give the, do you have a 10 centimeter? Give me the longer one.
Yeah.
If you have it. Typically, with what I'm doing, we use a short sheath, but I don't have that ability, but we'll see. I was able to dilate the tract there. See if I got where I wanted to go.
You done?
I think so. Okay. I'm just making sure that the sheath is still in place, and it looks like it just entered right there. But it's hard, so I'm going to just take out the introducer to double check. With my access in.
Do you use prophylactic antibiotics in any of these patients?
We do not. But if a patient's been on antibiotics, we continue them with it. Do you have a longer sheet? I'm concerned about this, so just
Your chin, okay.
yeah.
You want to chin for the,
Although I could try it and see what happens. What you want to make sure is that you don't lose access, obviously. You want to make sure that
That one?
see.
look,
Yeah, that'll work. But let me just double check here. I think I'm okay. All right, I'll take, I don't need that. I'll take the
fiber?
fiber now. So again, as I said, we're going to use a never touch direct fiber. Typically, a case like this would take maybe 20 minutes. I'm not necessarily in my home ground, but we're trying to do it for explanation, etc. It's always good to have issues that you haven't anticipated so that you can see my workarounds. So I'm going to take the wire out. I'm going to place the fiber in. And unfortunately, it's not going as far as I would like it. I have to see what the issues are. We'll straighten it out. Gonna bend you out.
A question from Dr. Ahmed Daloufi. What fiber size do you use? And if you are going with 400 nanometer, can you use it without the sheath? Question from Dr. Ahmed Daloufi.
We're using a short sheath, but you have to gain entry. So. I don't know of anybody that has done that. So she's in severe
I
spasm.
think
at
also
this
you can
point.
go with,
She's in severe spasm, which is what you can see here, and that's unfortunate. So we can wait a little bit to see if the spasm breaks.
You can turn off the AC as well.
Can you turn the lights down for me for a second?
Yes.
So there's where I am hooked up here. Just roll this out a little bit. See what we can see here. And that's the flavor. Coming up. Flavor. And let's see. That the vein itself is spazzed. No. So what do we do at this particular point in time? So typically what I would do is I would wait approximately 15 minutes. I go back to my office and do paperwork. And this is brilliant that we've had this happen to us. So that being said, what I'm going to try to do is a few different little things that I can do here, but she's in spasm. So if you want to turn light on, I'm going to take this out. Can you decrease the, turn the aiming beam off, please?
That's a bit.
See if I can. Advance together. I'll take that wire back.
Okay. There is any question that you have right now?
Yeah, that's what I thought. All right.
If you want, Kabnick, you can start the other leg while this one
We're gonna
spasm is
do
over.
that while it's in spasm, and I think that's exactly what we're gonna do right now. I'm gonna straighten your leg out. We're gonna bend this one out.
Gladys, compresa del otro lado.
Jump, please.
Vamos a tapar el lado.
Jump, please.
Ya.
Allá está la camilla, Gladys. En la camilla está el
La ligadura.
We're gonna turn the auto up.
Ok. Mover eso como quiere.
Clockwise. Clockwise. No,
Hacia el lado del reloj. Otro lado.
keep going. Thank you.
La ligadura en este lado. Quiero la ligadura.
See that? It almost looks like a Cheerio. See it? In the center of the screen. It's got a very thick wall now. She's in severe spasm.
The other one as well, yeah.
Yeah. And so I'm going to give it a shot, but I'm not sure that that's going to work. Because now you're talking about a lumen of maybe a couple millimeters.
Yeah.
Try it. Now, in my office, I would use nitro paste. And that would dilate it. The other thing you can use is some warm
Check the phone.
towels. Gosh, I can hardly see it.
Did you see that? Ay, someone going. Then, ay,
You see my needle coming in. I'm going to dent the top of that vein wall. I'm going to push it in again. Back it up a little bit. I'll take the LN8 wire, see if it goes in. Take the end of that wire, Javier. Thank you. Yeah. Sometimes it's better to be lucky than good. All right, I will take that knife again. I'll take the long sheath this time. While I'm waiting, I'm going to dilate the track. Yes. I'm going to just dilate the track. Well, not that one, that's too short. Too short. Oh, where's the long one? I need the bigger one that you had.
What, the 6
Oh,
French?
sheath, yeah, because I,
Okay.
this is a 4 French. I'll take the end of that fiber. Have that end of the fiber. See,
Check that now.
I just see something. If it'll go through this. Yes, it does. Okay. All right, I'm gonna, little pressure.
Any questions regarding about how we are here right now?
I will take the fiber.
Yeah, blood is coming. Very good.
We know we're in, don't we? Right?
Yeah, excellent. One of the tricks we use, we turn off the AC during the pre-puncture thing.
The room is warm, it's different than the other place, and all the fluids are warm already. We never have air conditioner.
Victor, can we
So
Very
I'm
good.
at the
Victor, can we
junction now.
unmute Dr.
Ladies
Faisal?
and gentlemen, I'm at the junction, and you can see my fiber moving. And so I'm going to typically pull back a little bit more than halfway of the screen. I know the total screen is about 4 centimeters. Victor's going to measure me. He stepped out of me. Hey, Victor.
Yes.
You going to measure me?
Yeah.
So, Victor, if you can unmute Dr. Faisal.
Okay.
Thank you.
That's good. So I'm right there. I'm at 218. So that's good enough. And I'll pull it back just to make me a little comfortable. There we go. So the question is, how much do you really need to ablate? And
do you do crossectomy?
Yeah, I'm sorry. Yeah, I'm talking about crossectomy.
Do you do laser crossectomy? Yeah.
Some people go to ground zero, which is laser crossectomy. And what they've shown is the following, that allegedly they decrease the amount of endothermal heat-induced thrombosis. But I've studied that for 16 years now, and I'm not so much concerned with an EHIT2, which is less than 50% cross-sectional diameter. And I might be somewhat concerned with an EHIT3. But again, if it's a total occlusion, that's a different story. The other thing that they found is that they can take care of the anterior saphenous vein at the same time. Now, the anterior saphenous vein, as you know, can cause a recurrence because in about 20% of the time after you close the great saphenous vein, within about 5 years, that anterior saphenous will also reflux. However, I am one to believe that if it's not broken, don't fix it. So the other problem that you see is we haven't spent long enough looking at ground zero or laser prostatectomy. And so even our colleagues in Latvia that are studying this ad nauseum haven't spent long enough. But think about it. If we see neovascularization a lot with stripping, because we're ligating every tributary of the junction, why wouldn't we see that with laser prostatectomy? And I would submit to you that even without doing laser prostatectomy, we have neovascularization in about 2.5%. So with laser prostatectomy, I suspect it's going to go up, maybe not like stripping because you leave some of that tissue open. In other words, some of the intima after you ligate, but I don't know. So I'm not necessarily a fan of laser prostatectomy. There's a study now being done in Germany looking at doing prophylactic anterior saphenous veins with laser. So you do anterior saphenous, you do the great saphenous at the same time. And the question is that helping? Well, we're not sure yet. There are going to be 2-year results. 6 months where, you decrease the amount of recurrence, but you're occluding at least 70% of the veins that were normal. Should we be doing this? Anyway, I'm going to move on. I'm going to do tumescent anesthesia now. And so tumescent anesthesia is done the same way as we do under access.
1 minute,
Sure.
just to break that and put something on.
Sure.
That one. Vamos a taparle, por favor. Give me that.
So with the other one, if she's still in spasm, what I will do is a different, probably go up to where it's not spasm. And then I'll ablate proximally and do maybe distally, foam scleral.
Levantar un poquito la pierna.
Victor, if you can unmute Dr. Faisal, he's sending a message to the chat box. If you can unmute Dr. Faisal.
Paren my detalle. Bueno, él iba a hablar de detalle. Okay. Okay. Gracias.
So typically I use a 22 gauge hypodermic needle that's 7 centimeters. This is not what I have here. So we're making things adjust. Also, another trick is that I have a pump being used here and I need to get the air out of the line because air, as you know, in ultrasound doesn't work very well. And you'll see some what I'm talking about, hopefully not, but I think you might. And so that's what I'm going to do now. I'm going to do some tumescent. And so I'm starting right at the beginning so that if I do get air, it won't be a problem. And essentially what you want to do is make sure that you have enough tumescent anesthesia so that you don't cause any issues in terms of anesthesia. And you can see my needle far off in the distance there. So I'm going to bring that down and change the location here. You can see it coming in here. And remember, the vein lies in its own compartment. So it's called the saphenous compartment. And so you pretty much want to circle that. So what is enough anesthesia here? Enough anesthesia is really to be at least 10 millimeters or 1 centimeter from the skin. And if you look at screen right, you can see numbers 1, 2, 3. So from the top, we are about 1.5 and I'm pushing. If I turn this on long axis, you can see in the center of the screen where you have a hyperechoic area. And that is where your fiber is. And you see about a 10 millimeter diameter, which is great. And then the other rule of thumb is approximately 10 cc's per centimeter. And there's some gel, please. Lots. Thank you. Pinchazo.
Pinchazo. Ver un poquito. Sí. Ya está. Ya.
Okay.
Ya.
She okay?
Yeah, sí.
Ask her, will she be okay with me to go through the way home on? So typically we allow patients to go back to work right away, especially if they, executive job or desk job or at max, it'll take a couple of days. They're not too big on giving days off now, at least in the United States with this type of procedure. Now, the other thing that's important, which when we were first starting out, some patients would complain of pain, and that's when we used a bare tip fiber, and they would go to the emergency room, and the emergency doctors would get an ultrasound, and they would say to the patient, you've got a superficial phlebitis. You need to be, you know, because it's long, you need to be on anticoagulation. So warn your patients that they may have experience some discomfort in the beginning.
So going to the same thing, superficial thrombophlebitis, do you wait like 3 months before it heals and then you go do a laser?
Laser what, sir? I'm not following you.
Where is your, first of all, where is located your superficial
Yeah,
thrombophlebitis? Where is the
yeah,
saphenous
if you have first of all an STP.
Are you talking
Yeah, if you have a
spontaneous?
patient with varicose,
With
yeah,
what?
if you have a case with varicose and then he got a varicose vein and then he got STP, when do you treat him?
Good question. Usually we wait for 3 months because we know that at 6 weeks is usually the time that the hypercoagulability, et cetera, is decreased and the inflammation is decreased. But the rule of thumb, and everybody follows, as far as I know, is 3 months. Is that what you follow? Do you do the same?
Yes, we wait for 3 months.
Okay. So you can see that I am pretty much up at the junction. You can see where my probe is. You can see where my needle is. So what I like to do is I'd like to go past it a little bit and then also give some tumescent below it. And that kind of circumvents some of the heat
Yeah,
from going
that's
north.
important.
It also, remember, the posterior fascia has some nerves.
Yes. This is a very nice
So you
trick, giving posterior, especially in the upper part.
So I'm just making sure that we're good. Now, the question that arises is how much energy are we going to give? And so the question on that one is, it depends on what machinery you're using. Can I have a cap? And it depends.
Okay, forget about it. Just give me them. I will just give me them.
Just leave it there in case I need some more. It depends on what laser you're using. If you're using a water-based laser or hemoglobin-based laser, or what curve you're using on the water absorption curve. So typically we started off with a A10 940, which were hemoglobin based. And then we moved to a 1470 because we understood that the absorption was much better. You needed less energy. Now, depending upon the equipment, depending upon the fiber, also depends upon how much energy you're going to lose. So in this particular case, we're using a diffusion fiber, never touch, and we're going to do something between 5 and 7 watts, and I'm going to go with 6 watts. And typically we'll do between 40 and 60 joules per centimeter, and I always go a little bit higher. So if we know our physics, excuse me, ladies. If we know our physics, we know and understand that watts times seconds is equal to joules. And we know that we want to deliver approximately 50 joules per centimeter. So that means setting at 6 watts times X seconds will equal 50. So that's approximately 8 seconds, because 8 seconds times 6 watts is about 48 is 50. So that's what we're looking at. Now, if you're using a radial fiber, it tends to use more energy, and you'll hear settings much higher than that, and how many joules they're actually using, up to 80. But again, it depends on what machine you're using, and it really depends on the output of the machine. So every company has different outputs, etc. So I don't typically watch my fiber, but I wanted to show you what it looks like. So here I am. You can see the damage that's happening. People think that that's steam bubbles, right? Well, it's really not. It's because if it was steam, you would lose the ultrasound effect. It's probably pieces of the wall, probably some blood cells that you're seeing carcasses, and there may be some steam bubbles. The majority is not. If my friends would count by 50, that would be great this time.
You
gonna
do not
50,
have to
okay.
use protection goggles.
Do
The
you have
laser.
to use protection goggles? Obviously, I'm not. And the reason is that the idea is that you are inside the leg. Unless you take a direct shot to your eye, you're not going to have a problem. Now, that being said, when my laser safety officer came to our procedure room at university, we all wore goggles. We all have signs, etc. But it's never been shown really, unless you take a direct hit, that it's problematic. But I will tell you, when you start, for my safety, is you should wear goggles. I'm in control and I know what I'm doing. So again, those people that are beginning, absolutely wear goggles. I will tell you that they are specific to the wavelength as well. So you got to make sure that you have the correct goggles. Thank you for that question. So I'm going to start again. And Victor's going to count by 50s in Spanish.
We usually have that kind of stuff for these foods, and you know, if you like it, you
Oh,
can use it.
that's pretty.
You see?
I like the pink. You want to put it on me?
Yeah.
No, I'm serious.
We got everything set up already, but since we are doing that for so many years, we just started. If you are concerned about that, you can use it.
And I forgot to count by 50, but I know what I'm pulling back.
50.
Bueno.
We will count in Spanish right now. Look at being that there are 300 so already we are given. We are counting about the energy. We are looking what's going on already.
You want to shut the lights off for a second?
Yes.
So we can show what we're looking at. So here's our aiming bead. Okay, lights back on.
And obviously you don't have to press while firing there, isn't it? In radio frequency, sometimes I've seen like we are pressing the site where we are doing it.
So the difference between laser and radio frequency is laser uses convection, induction, and radiation. In radio frequency, it only uses conduction. So the catheter needs to hit the sidewalls. So if it's not hitting the sidewalls, then you're not getting proper ablation. So that's why we use hand pressure or probe pressure on the radio frequency catheter.
Do you give it like a double shot in the junction?
Do I give a double shot at the junction?
550.
Are you talking about radio frequency now?
No, laser.
No.
No.
We answered that simultaneously.
So,
No worries. But if you notice, what I did was I kind of stayed at the junction. So I guess maybe you're right. I basically stutter step up there. So I moved the laser fiber very quickly in and out, maybe a millimeter or so it doesn't stick. But yes, I guess you're right there. And so I am going to watch the aiming beam a little bit. And Victor's going to count again. But I know roughly how slow I have to pull back.
it went up. All right. And check also your
Catheter.
your catheter. There is some measurements of the catheter that we are counting.
50.
And I'm right there, and I'm gonna move my catheter out. And I'll show you what Victor's talking about. You see this area right here? Depending upon what size sheath you're using, depends upon there. And typically, a short sheath which comes with this kit, this is the area where you're gonna start to pull back your sheath so you don't burn within the sheath. I've got all these able assistants, so I'm happy.
You have to know that our patient is awake and we are not just, she's relaxing without big trouble.
She say hello.
Yeah.
50.
Raquel, ¿te duele algo? Okay. She's quiet and sleeping.
Hello,
No.
hello.
Very comfortable.
50.
The final idea that we have over here is just to show that there is something that we can do in the office that is under lockout, and with the pump, you will be able just to fix the patient without big trouble. And we don't know all the requirements
50.
for an office setting that you, if you have everything, just to go to a hospital. The patient are really happy after the treatment.
50.
Now, do you use laser there or radio frequency?
I use radio frequency actually, and
it's a good-
I've
good
started with laser, but then changed to radio frequency.
Actually, I've done the opposite, radio frequency, and then I liked laser.
I use both.
50.
I'll tell you why in a moment, as I'm entering the end of my treatment. And now you see the no-fly zone where you don't want several hash marks, which means that you are close to the end. So that's what I'm going to do. I'm going to take it out and hand it off. Hold that place. Right. And that's the story. So with radio frequency, I find that if the vessel is straight and not tortuous, it's easy to do radio frequency. If the vessel is tortuous, it can be a problem, except with the new catheter from Becton Dickinson called Venclose. It had a little curve at the end of it, and that allows you to kind of torque a little bit. So what I'm doing right now is I'm just looking, and you can see some artifact up there at the junction, and I'm also going to compress the end of it. Now, do I look for color or openness of the vein? I don't, because in my practice, I've seen where veins are open right away and they close within a day, and some of them a couple of weeks. So the majority are closed, so I don't even look anymore. And in reality, I bring patients back at 1 week. I used to do that. And I can tell you that I was always checking for EHIT or thrombus extension. And I really don't do that anymore, except for those patients that are at high risk. And those patients that are at high risk, I'm going to give prophylaxis. In the United Kingdom, they prophylax just about everybody, and they don't see their patients back. They go to their primaries unless there's a problem. So that makes it easier that they don't need to do ultrasounds. So back to laser and radio frequency. Now, for me, there's dealer's choice. But I think laser, by and large, is more versatile. You don't need as much running room in order to close the vessel. Because remember, in radio frequency, there's the amount that you're going to ablate. And it used to be 7 with Medtronic, now it's 8. And with Venclose, it's 10 centimeters. So you need that. But the interesting thing about Venclose is the same catheter, you push a button and it drops down to 3 centimeters. So you only need that one catheter to do shorter vessels. So if you do the great saphenous and the anterior saphenous together, you may drop down, and you can also get to a point where you're closer to the exit site by using a 3 centimeter run. Now, when it comes to perforators, there's no question in my mind that laser is superior because you can put a bare tip fiber through a 21 gauge needle into the perforator and close it. The
Yes.
Medtronic device, which I used in the beginning, has its issues. And now Becton Dickinson, called the Maven, which is out there, is a little bit easier. And you go directly into the perforator. It's done through an access sheath, and it's a little bit easier. But I still think that laser is a little bit superior. Now, when it comes to efficacy, a randomized controlled trial with laser showed somewhere in a 70th percentile. And in single arm studies with radio frequency, they were better. Same thing with laser. But the reality is that, if you get 70, 80% closure rates, you're doing well. Now, why do you have perforators that are open? And that's another discussion, but we can think of proximal May-Thurner or previous iliofemoral epineliacs. And so even if you have perforators that are open and you have great saphenous, you should do the great saphenous ablation first, because the number of those perforators that are incompetent will then become competent. And the same thing with if you have proximal obstruction or central obstruction, iliofemoral area, then if you take care of that, then things are. Are we snoring? Oh, okay. Sorry, I was just trying to figure out what was going on. But that's it. Are there any other questions that I can answer?
Yeah, I wanted to add, the machine I'm using is F-Care, which is Swedish machine, but the probe is about half a centimeter. Yeah, so that's the machine I'm using. So it's not really long, the closure fast one, and I've been using it for some time now, and the results are okay, acceptable. And the same machine, I can use different probes for even perforators, and also they have the ability to also use for the spider veins as well as a needle ablation, like from outside. So that versatility is actually the thing which made me to start using the radio frequency. But
so I've worked with F-Care, and I know there are people have they developed a bipolar RFA, because it used to be monopolar?
Yeah, it is a monopolar, I think.
Okay, and I know about doing spider veins with it, but you really should do combination sclero and laser if you're going to do that, unless they're the little tiny telangiectasia, the red wispy ones. But that's good, and you're economizing, and if you're getting good results, that's great.
Okay.
Yeah, I do. Yeah.
Finish with them. The webinar we did already one time. So, finish.
Any other questions before we sign off?
Well, I can't see any. Ayman, do you see any in the chat box there? Any questions?
No, I have a question, Kabnick. I think you have talked about it a little bit. If you have a central problem, like iliofemoral post-PTS and stenosis, in addition to reflux, of course, would you like to start in the beginning upwards and going downwards, or what's your protocol?
Could you repeat your question, because I didn't understand.
Yeah, if you have an iliac problem, May-Turner post-thrombotic syndrome, in addition to refluxing saphenous.
So post-thrombotic syndrome, I'm not sure we understand what that is anymore. but I understand how I think you're using it. And if the patient has reflux, so my personal opinion is you treat the patient. If the patient really has post-thrombotic syndrome and it's really caused by outflow obstruction, then it makes sense for me to treat the outflow obstruction first. Do you agree?
Yes.
And then if the patient is all of a sudden better and has no issues, the question is, will you take care of the great saphenous that's refluxing if the patient has no symptoms? And in my feeling, the answer is no. If the patient has symptoms of heaviness, achiness, swelling post that, then I would treat it. And then the question really is, if you have C6 disease or ulcer with the patient, and you have outflow obstruction, reflux, and an incompetent perforator right below the ulcer, which one do you treat first? And that's the quagmire,
Yeah.
because everybody has a different opinion. But for
Yeah.
me, I
Yeah.
tend to go with outflow obstruction because if you think about it, the deep venous system is your return, and your deep venous system carries a whole lot more blood than the superficial system. So I really think the outflow obstruction, in my opinion, should be treated first. And then go to the reflux and treat the truncal vein reflux. And then if there's any question that the perforator hasn't become competent, then I would treat the perforator. And then the last thing that we should talk about is the venous plexus underneath the ulcer bed, which should be sclerosed.
Yeah.
Prof, do you use
So
A very
any
illustrative.
medications post procedure like venotonics or something like that, like Daflon and all these things, sort of?
So the venotonics are not really utilized in the United States very much, but honestly, I think they do add some quality of life improvement. With venotonics post-procedure, there are people that use them like Daflon or horse chestnut seed extract or whatever that they do help. And one of the things that I found when I had patients coming to me with Daflon on it, and they were in the United States and we took them off, they did start to complain of symptoms. So I do think that there is some legitimacy of that. And I also think that when a patient first comes to you, you might want to consider using a venotonic agent to see if their symptoms are helped by that. Agreed.
Right.
Well, I thank you for allowing me to show you a vein problem that got in a spasm. But in reality, what I think happened here was that I used a short sheet and I was not able to really cannulate well, and the vein proximally went into spasm. And with the other one, because the vein was in spasm on the right, she reacted on the left as well. And so, but fortunately, I was able to show you by grace that I was able to enter a very small vein by ultrasound and complete the procedure. But thank you for your patience.
That was brilliant, Prof. Kabnick. That was because of the skills you have, of course, and that was very interesting and very fruitful. And thank you very much for going through the whole session. And we have really enjoyed the whole explanation and the details which you have been through and the questions you have answered. And I hope we have some more session in the future. But then for now, I think thank you very much to you and to your colleagues, all of them, and to the patient as well for agreeing to transmit live. And wish you all the best. Thanks.
Okay.
Same to you. Thank you very much.
Thank you very much for everything. I just want to say thanks to Lowell and all the team that you have here, my nurses, Gladys, Victoria, and Letty, and also Dr. Canata, who is helping us. I think we have a great day today. Thank you for everything. Thank you for all joining us, and we will just see you around. Have a good one. Okay.
Thank you.
Bye-bye.
Bye-bye.
Thank
Thanks.
you. Thank you. Thank you, everybody.